I'm going to be arguing against health partnerships. Thanks for Thet to invite me along today. I think it's great that they're doing this, and it's really good to have the discussion. During my kind of devil's advocate role against the motion, I'll draw on some of my experience of involvement in a health link in Cambodia, and then several other pieces of work I've been involved with. So the first question in my mind is, what is an appropriate and sustainable approach to international development? And we could debate this, but for the sake of argument, I think the Department of Health framework for international development outlines an appropriate approach. I think it's kind of in sync with the principles we've already heard today, that effective development assistance should be led and driven by the needs of developing countries, the principle of ownership, aligned with government health plans, adequately coordinated with other development partners, evidence-based and subject to proper monitoring and evaluation, sustainable and mutually accountable. So health links should aspire to do all of these things. I guess my first question to the audience is, does your health partnership do all of these things? And if so, does it do them well? We'll come back to these, but ultimately I think health partnerships are about improving health in a kind of equitable, sustainable and appropriate way. So health links do make international development accessible to us compared to alternatives such as NGOs and the WHO, which can be quite hard to get into, but do well-meaning clinicians like us know how to do appropriate and sustainable international development. So my first question really is, there's those principles. My first question is, do health links improve health outcomes in developing countries? I'm not really talking about a service delivery partnership where medics go out and perform hernia operations, talking about sustainable long-term improvement in a population's health. I think it's hard to evaluate the impacts of health links, for example, contribution towards Millennium Development Goals. I think in some ways they're too small and their activities are kind of too disparate. It's easier to count outputs on the logic chain. For example, number of people trained, number of workshops conducted, the kind of bread and butter work of health links, but harder to establish critically, I think, if this leads to longer term changes in practice or improved health services. So I conducted a literature review on the kind of published and unpublished literature of health outcomes of health links, and I did find some evidence of improved health outcomes. For example, one health link demonstrated improved TB mortality before and after its intervention, but I couldn't find a lot. I think it's not to say that health links don't result in improved health outcomes. I think it's just hard to measure, and we maybe need more evidence. I think it's easier to evaluate processes, kind of the inputs, activities, and immediate outputs of health partnerships. And there's an argument that if we get the processes right, then good outcomes will follow. And my second point is that health partnerships don't always get the processes or approach right. I'm just going to highlight some examples from an evaluation I conducted that sought the Cambodian perspective of a health partnership with the UK. So I conducted interviews in Cambodia with Cambodian health workers, Ministry of Health officials, villagers in the population served by the link. I will stress that lots and lots of good things were said. This is my job today to highlight some of the negative things. And I was really seeking evidence of these good practice principles such as ownership, alignment and a sustainable approach. I think there was perhaps some discrepancies between what the partnership was doing and what the developing country partners wanted. I'll just give a few examples. So number one was around contract lengths. So NHS staff typically have placements in Cambodia of around 3 months, sometimes more. So here's what one of the Cambodian health workers said about contract lengths. I think it's better at least 6 months. Sometimes they just have 2 months. Sometimes they just learn only that. Then they have nothing to implement, and it's time for them to finish the contract. So again, the question is really, who is the beneficiary there? Does this result in sustainable change? Is this medical tourism or international development? And I think it's usually a great experience for NHS staff, but is it effective international development? So, my second example, again, in many cases this will be the first time that NHS staff have worked in a developing country. It raises a question of, do we know what's the appropriate approach for the setting? So here's what a district Ministry of Health official said when asked about whether work was in alignment with Cambodian Ministry of Health policy. So it said, Westerners came to teach staff at the health centre, and I found that the training was good in terms of skills and techniques, but some techniques and skills had not been allowed at the national level, but they had already done that. And again, is this a sustainable approach, and what is the effect here on the wider health system? My third point really is about attitude, and just to challenge the assumption that everyone involved in the UK partnership has a good attitude. So is what one Cambodian health worker said. To work with 10 people that have different characteristics, different ideas, different skills, experience, this is my problem. Some people, whenever they come, it seems like they want to command me or to order me to respect them, to follow them. Just one or two that I met with. My final example, probably by now around 30 NHS staff have undertaken placements in Cambodia, but no Cambodians have yet visited the UK. So it's what someone said about reciprocal visits. You sent, I think, maybe around 10 people to visit Cambodia to help us. We've never seen anyone from Cambodia visit activities in the UK. So I'm now in Cambodia and I've never seen the UK. I do not know how well or how successful you're implementing in your own home. So there we go. I think, I'm aware that health partnerships are set up in different ways, so I can't generalise for all of them. But I think we need to get the approach right. It's imperative to do everything we can to mitigate unintended consequences. Similar sentiments to what I've said have been expressed in other evaluations that seek the developing country voice. For example, a DFID evaluation in 2008 reported that factors affecting links effectiveness included degree of developing country ownership, alignment with country health plans, and length and number of one-off visits. So what I was hearing in Cambodia isn't necessarily new. But I think there's a lot of good things about health partnerships. We won't necessarily hear the negatives unless you ask everybody who's participating in them. We won't get everything right, but I think the best quality a health partnership can have is willingness to learn, evaluate, reflect, share learning, and then adapt. So I'm just going to end by telling you a story about my Cambodian friend and colleague, Dr. Le. He's given his consent, put his photo up today. He's hosted around over 30 UK health professionals. He's shown them local health facilities, explained the Cambodian system, healthcare system, sort of again and again. He's been really great. And myself and Dr. Le were successful in obtaining a Royal College of General Practitioners international travel scholarship, so a fully funded 2-week study trip to the UK. This was over 2 years ago now, but unfortunately his visit has never happened because his visa application was rejected, despite letters on headed paper, proof of funding and all sorts. It's been quite a difficult process. And my point here is that partnerships can't be true partnerships unless these kind of systemic obstacles, such as obtaining visas, can be overcome. It's not a criticism of health partnerships per se, it's rather the system in which they exist. So I'm channeling my frustration here towards the UK Border Agency. But I couldn't resist the opportunity today to do so with the large audience. So, in summary, I think health partnerships can offer an appropriate and sustainable approach to international development. We need more evidence, perhaps, of health outcomes to support them, cost effectiveness. We need to get the processes right, but they can do it if they're done well. Thank you very much.